So my presentation is essentially about a solution to try and deal with the more complex type 3, 4 Sanders calcaneal fractures in patients who are not suitable or are in manual labor so that they can perhaps go back to their jobs earlier. So this is one of the important things about calcaneal fracture, that when you're treating fractures, one should anticipate future difficulties before they arise. And with calcaneal fracture, there is sufficient certainty of future trouble to warrant arthrodesis with reconstruction to avoid prolonged disability. So it's these fractures that we have been looking at and trying to find a solution. And this literature clearly says in the early 1990s that type 3s and 4s, nearly 23% and 70% went on to fuse, but this number has increased to 20% and 50% in 2014. The average time that a patient with such calcaneal fracture goes on to have arthrodesis is between 1 and 2 years. So what variables will predict that patients will have subtalar arthrodesis? It's usually a male, a heavy manual laborers. They might be on workers' compensation. If their Borer's angle is less than 0, they are Sanders grade 3 or 4, and they may have had non-operative management. So we looked at these series of patients in a retrospective manner, and all patients who underwent fixation first and then subtalar arthrodesis at the 2 hospitals. So the technique that we have used is a lateral approach initially, but nowadays we are using the sinus tarsi approach, and the aim is to first reconstruct the calcaneus, the height, the width, and the axis, elevate the articular surface, debride it, fix the calcaneus, and then fuse it with a variable pitch screw. So the picture on the left top is how we used to do it some time ago with the extensile. The picture on the right is the one that we use now. It's the sinus tarsi approach. Even though the exposure with the extensile lateral is better, but the sinus tarsi is better for wound healing. So once the sinus tarsi is made, the peroneal tendons are identified, they're taken out of harm's way. This drops you straight into the subtalar joint, where you can see quite clearly the posterior facet, the middle facet, and the undersurface of the talus. So once the exposure to the joint has been done, we first try and elevate all the soft tissue off the lateral wall of the calcaneus and try and reduce the expansion of the lateral wall that occurs in most of these calcaneal fractures. The aim is to reduce the fracture first. So using a Shan spin, we try and correct the width and the varus, then the height, and bring the length out of the calcaneus as best as possible. We are not trying to recreate the calcaneus. We are trying to get the heel to fit into a shoe, and at the same time, bring the articular surface elevated enough so that we can do a proper arthrodesis. The plate of choice for us are these. They are the wave plates, and they can be reduced through the sinus tarsi using a jig and under image intensifier placed on the lateral wall and fixed in the photograph that you see at the bottom. So in our case series, we had only 9% were Sanders 2, and the majority were 3 and 4. And the results, we had 18% complications, essentially superficial wound infection. Some returned to theater for removal of metal, but they all returned to work within 6 months' time. So here's some examples of the cases that we have done. Preoperative appearance of the calcaneus fracture, CT scan and plain X-ray. And this is the post-op appearance where the whole calcaneus has been reduced, the articular surface elevated, held with the wave plate, and then fused with a variable pitch screw. Another example, this was before we used the wave plate, and this is the one with the wave plate. And again, it shows that the fracture is fixed sufficiently well to show that the heel is not in varus, there is no lateral wall protrusion, and that the fusion is looking satisfactory. And this is the one that I wanted to show you. Before we had the wave plate, we used to use the malleable plates from the Synthes foot set. So this is our current practice now. If we do get a patient who got grade 3 or 4, he's a male, underwork compensation, age around 50 or above, with no comorbidities, we would go ahead and offer them this surgery. And if they're happy to go ahead, perform it so. So the advantages are, this is one operation, there's earlier return to work, no increase in complications compared to ORIF of calcaneus, but it has to be done on a carefully selected patient. Thank you very much.